I am sort of questioning the sort of suggestion that maybe this tooth needs a fibre post or not. As I pull out this GP cone, we can see now we've got a really, really nice small little hole. Looking back when I was editing this video, I feel like maybe I should have used some kind of 3506 tape, and we can see here that we've got a really, really nice restored tooth. Hello, welcome to this week's clinical case, and today we've got an unusual sort of restoration that I'm going to place on this tooth prior to doing the root canal. And I suppose on reflection, the great thing about these videos for me personally is when I get to edit these videos and I reflect on my cases, I get to learn things myself. I look at things where maybe I should have done some things differently, things where, I was happy with. And throughout this case, I suppose this was a unique challenge presented to me from an external referral. And, I thought to myself, maybe doing it this certain way would be a good idea. And I feel like in this case, it has been a good idea. But there are a few little tweaks that I want to kind of add to this as we go along. And this is the great thing about these videos. Like I say, it's all about reflection. Sometimes you look at cases that you've done in the past, and you're probably your own worst critic. In some cases you think, oh god, that was the worst case I've ever done, and then when you re-look back at them, it doesn't look so bad. So before we get into the video though, and before I introduce the case, what I want to say is that over 50% of the people who watch these videos on YouTube are non-subscribers. So if I could ask you to do one thing before we move forward, is just to hit that subscribe button. It's free and it's easy to do. And then if you want to bring the support to the channel even further, we've got a membership program. The membership program gets early access to content. I usually run about 3 or even 4 weeks ahead with the content. So if you love this video and you want more, join the membership program. We've also got an exclusive content. We've got an access video. It's an hour long. It's fantastic. Loads of videos, loads of pictures. And also soon we'll have another exclusive video for root canal for newly qualified dentists. So we'll get into the case. So we're looking at the periapical radiograph here, and this is a PA of a lower left 5, okay? And when I received the external referral from the dentist, they had suggested that the tooth was necrotic, and it will need root canal, and also need some sort of post. And we consented the patient, we did our special test, and the patient was saying that this tooth was sore, and it come up with a diagnosis of irreversible pulpitis. However, if we move over to the video here, I am sort of questioning the sort of suggestion that maybe this tooth needs a fibre post or not. Granted, there's lots of decay in there and that needs to be removed, but I think maybe there might be a significant ferrule there for us to have no post at all. Of course, having a post can weaken the tooth, but in the first instance, I'm just going to remove all the decay from this tooth and just reassess. And also what I'm doing is I am just opening up the orifice of the canal, ready to do this novel sort of restorative technique. And then once we've removed all the decay and I've opened up the orifice, I can see that I'm actually questioning the fact that this tooth actually needs a post or not. I feel like, in the distal aspect, yeah, there is at the gum line, but I would say over 75% of this tooth is 2 millimeters above the gum line. So in my book, putting a post in this tooth is probably not worth it. I do place a matrix band. The bad thing about a matrix band is it doesn't give you a good contact point, but I know that this tooth is going to have some kind of indirect restoration. So I'm going to get ready for the restoration. I'm going to etch here, and then once I etch this tooth and I give it a bit of a clean out, I think that maybe there's sort of there's possibly a buccal canal. So I can see that the canal orifice is a bit oval. So what I'm going to do is I'm going to get some low energy ultrasonic tips just to remove the buccal aspect of this access cavity, just to kind of see if this tooth is or isn't single or double canaled, and then give it a little bit of an ultrasonic, and I can see here that this is just the shape of the the pulp chamber. And if I kind of annotate here, I'm just going to sort of roughly draw what I think the pulp chamber looks like. I think it kind of looks like this kind of L shape here. So I'm quietly confident this tooth doesn't have a double canal. And then I'm going to pick up size 60 O2 tapered GP cone. Now, you know, we were talking about reflection before. I think looking back when I was editing this video, I feel like maybe I should have used some kind of 3506 taper. And if we could sort of look at the two GP cones next to each other here, you can see that the 3506 taper has a much wider taper, and you'll see later on that when I use this GP cone, it doesn't give me that kind of wide opening for us to shape the tooth. And then I'm going to place the GP cone in the canal. This is going to block the canal for when I fill this cavity with composite. And then just to remove the excess here so it doesn't get in the way, I'm just going to snip off the GP cone. I'm not using rubber dam. You can see here, I'm just packing the buccal aspect of this tooth with cotton wool. You know, I could have packed it with the lingual aspect of this tooth as well. And also you could argue that I should be using rubber dam, but I suppose in a way my area of expertise is root canal and not restorative. And in a way, you know, I know my limits. Okay, so some dentists out there are absolutely fantastic with rubber dam, and hats off to them. But in this case, I feel like I've gained enough of a clean working field, a dry working field to place this composite filling. But I understand the downsides of not rubber damming this tooth. So we've blocked the canal. I am just about to place eye bond. Again, you know, got to be really, really careful not to get this all wet, and I'm asking the patient to breathe through the nose. And then once we've etched and bond the tooth, I'm going to layer it with a composite, and in this case I'm using SDR. I feel like this is quite a tight sort of tooth to kind of get a bit of composite in there, so in the way I'm just nice and easy, I'm just using a sort of bulk flow composite, and I'm trying to layer this as best as I can because I'm worried about C factor. And then straight away I'm going to place our rubber dam once I know that I've sealed off the tooth, and give it a bit of a clean up. And then as I pull out this GP cone, we can see now we've got a really, really nice small little hole. And I suppose in a way it's a nice conservative access, but it's just not, it's not big enough for our instrument. So I'm just going to use a 25 variable taper high flex file just to open this up a little bit. And then when I look at overall the composite itself, now I've got the rubber dam on, it looks a bit rough. So what I'm going to use is a fast handpiece just to kind of really remove the tooth from the occlusion completely, and just use the fast handpiece in the hole. And we can see here that you know, we've got a really, really nice restored tooth, and the access is looking super neat. We like a bit of neatness, and then just a bit more adjustment with our white stone. Ready for our irrigation, first thing we ever do. And notice that I'm using Irriflex tips here. It's got this double side venting action here, which is fantastic. It's also made of plastic, so it can bend really, really nicely. And if you can imagine how tight this access cavity is, if we were using a stainless steel needle, it probably wouldn't get that far. But you can see here with this Irriflex tip, it's really, really flexible, and it gets down there and it irrigates the tooth really, really nicely. Now, when we look at the x-ray, I feel like the canal space is quite open. So I'm going to go straight for our working length. And, you know, if people watch a lot of my videos, they know that I like to, with a working length, like to push the hand file out to the end of the tooth just ever so slightly. So we go past 0 and we back it up. And then when we get to the 0, as we're backing up, that's our working length. And we can see here when we measure this size 10K file that the working length is at 23 millimeters. So we're all ready to go. We've restored the tooth, arguably the hardest part. We're now ready for our glide path file after we've done our working length. And as you know, I like to use my glide path file at 0. So I'm going to measure this size 10 high flex file at 23. And then I'm going to use this on quite a low torque setting, 1, and also quite a low RPM, which is 300. I don't think that is the suggested manufacturer's torque settings, but I just like to use that because I feel like if you are using a glide path file and you're on the lowest torque setting and you need to up the torque, then the glide path file should move to 0 passively. So if you're trying to push the glide path file to length, you're forcing this file, and it shouldn't be forced, obviously, because there's a possibility of ledging, and also there's a possibility of file fracture as well. So we've got to the 0 with our glide path file. I'm using now our master apical file. I'm using a size 25 variable high flex. The torque setting is going to be 2.5 Newton centimeters, and the RPM is going to be 400. And what I notice with this file, as I am sort of shaping this out, is that I'm getting a slight bit of resistance, and the worst thing for me to do here is to push this. So I'm just going to remove some of the debris from the file, and then you can see here actually the orifice now is quite nice and open. So we're sort of the diameter of this master apical file is opening up this canal space, but like I say, it's getting a little bit of resistance. So what I'm going to do is I'm just going to be very, very careful. I'm going to recapitulate. I'm going to get a hand file down there to 0. We're going to irrigate, and we're just going to very, very slowly use I'm going to very slowly use our rotary file until we reach the point which is 0.5 millimeters away. And then once we've shaped the tooth successfully, what I've noticed is there's a bit of an undercut here. And what I mean by there's a bit of an undercut, the canal space is actually oval shaped, or the pulp chamber is oval shaped, but the access cavity is round. And I think that this is going to be a significant challenge to fill with composite once we've obturated the tooth. And obviously, if we have a void, then that's going to probably be a source of failure. So I'm just going to use some diamond-tipped ultrasonics here just to remove this so-called undercut of composite. Because don't forget, we just flowed that composite in sort of willy-nilly. And as we can see here, that as we give that a bit of a clean out, we can see now that there's no undercut, and that's going to be much easier to fill at a later date. So because the access cavity is quite small, I'm going to have to use a smaller tapered GP cone rather than the matched GP cones. And this is a size 2504, a maximum diameter of 1 millimeter. And with these, I'd always like to check the end. And in this case, we check the end of this 25, and it is actually at 25. Shock horror. And then I'm going to measure this GP cone at 22.5 millimeters. So that's at the working length where the master apical file was. Just give a little check there that we're at the right working length with this GP cone. And then I like to make a definitive bend in this GP cone, because that's where I know where the actual working length of this GP cone is. And if you drop the GP cone, or I unhook it with my tweezers, I know where the working length is. And as I push this GP cone to length, I notice that the mark at which I've crimped this GP cone goes a little bit too far. So what I'm going to do is I am going to crimp the GP cone at the level at which it's been sitting, and I'm going to measure it, and I've noticed that actually this GP cone sits at 23 millimeters, which is too long. Okay, so what I'm going to do to negotiate this problem is that I am going to sort of do a little bit of apical gauging. So I'm going to recut the same GP cone at 30 ISO 30, and then I'm just going to remeasure the GP cone. Now it's been cut, it's been snipped down slightly, and that now measures at 22.5 millimeters. And I'm going to keep the tweezers crimped at that level, and then I'm going to place this GP cone to length. I'm going to feel for a little bit of tug back, and as we sort of push this to length, we can see now that this is fitting at the same level as it did. So it's likely that it's at the right level. However, I like to check. I'm going to crimp the GP cone at the point where we'd measured where it needs to be measured to, and then when we pull it out, it's found to be 22.5 millimeters. So we're going to place the cone back to length, and when we take our Comfort radiograph, this looks absolutely beautiful. You know, there's a little bit of a suggestion here, maybe that this tooth is a double canal, mainly because you can see this kind of, maybe on the mesial aspect of this tooth, there's maybe there's like a tram line, but what you'll notice, and if you're weird like me, if you're taking teeth out as well as doing root canal, when you take these teeth out, they've kind of got this kind of ribbon shaped kind of figure of 8 shape, and I am almost certain that, given our investigation, that this tooth has got one single canal. When the x-ray is just getting developed, I've started to do this new thing where I just replace all of the dirty things on my tray table. So I just remove all the instruments, I change my gloves, I then give the tray table a bit of a wipe. We've got a new paper towel, and then I'm just preparing for the obturation. So I've got my disinfection ring. We're going to fill that with sodium hypochlorite, EDTA, and here we're just using a bit of isopropyl alcohol. And I'm just getting all my instruments all ready. I'm also getting my hand file ready and disinfected, ready for obturation point. And it's all looking nice and neat here, and it's all looking like it's ready to go. So I'm going to remove the GP cone. Once we know that the x-ray has gone through correctly, I'm going to place this in the sodium hypochlorite, and then I am now ready for my final irrigation protocol. And in this case, we're using sodium hypochlorite as an initial rinse, and then I use this 18th ultrasonic irrigant activator. And then I'm going to use, like I say, first step is sodium hypochlorite activated, EDTA activated, and then a final rinse of sodium hypochlorite activated. We're then ready to do the drying, and I am really concerned about length control in this tooth, because I was worried about length control in the GP, but I'm also worried about cross-contamination. I know my measuring block is not sterile. So what I'm going to do here is I am going to get a sort of a test paper point. I'm going to measure it to 22, and then I'm going to use this cone as length determination. I'm going to make quite an acute bend in this paper point, and I'm going to put this to one side. And then I'm going to get the clean paper cones, and then I'm going to measure this next to the one that we know we've measured but it's dirty. And then this is going to stop me from pushing the paper points through the apex, which is a surefire way of making the inside of the canal space bleed. And we can see we can do this, repeat this until it's nice and dry. We're then ready for our obturation. I'm going to get everything ready. I'm going to load up my bioceramic sealer with our visco tips. And then I'm going to get my hand file. I'm going to give this a little bit of a dry, get rid of all the sodium hypochlorite. I'm going to place this to one side, and then I'm going to pick up my GP cone, and I'm going to dip it in isopropyl alcohol to get rid of all of the sodium hypochlorite residue and give that an air dry. And then the reason why I do this is just get everything set up and ready. So all I have to do is just pick each item up. I don't have to muck around. If something happens and I'm not, one step isn't taking longer than the other, and you might get a little bit confused. So it's great just to have everything all ready and rocking to go. First thing we're going to do is we're going to directly inject the sealer into the canal space. Again, I'm using high magnification, so I can do this quite safely. Once we've done that, I'm going to pick up my hand file, my disinfected hand file, and I am going to place this to about 1 millimeter or even 2 millimeters away from the working length. This just introduces the sealer all the way to the end of the canal and also stops vapor lock. And then I'm going to pick up my GP cone, and I'm going to fit this very, very nicely to length. And notice that I've got all these steps already, and it's all just happening really nicely. So this is why we like to get set up before we start doing anything. And then the GP cones to length, there's a little bit of a bend on this canal, so what I'm doing is I'm just very gently pushing this GP cone to all the way to the length, and what I'm looking for is where I've snipped this cone off, it's fitting to the point where I've snipped it off. Okay, so this GP cone now is fit nice and snugly to length. We're going to just cut the excess off with our heated plugger, and I'm just looking at all my heated pluggers here, and I'm looking for the smallest one, mainly because the canal the access cavity is really small, and in this case I'm using a 0.06 heated plugger tip. So this is the smallest one. Usually I like to use the thickest one because it's easier to shear off the GP. And then, you know, all I have to do is just very carefully remove the excess. The problem with these narrower tapered GP cones is that they're designed to fit into the canal space really easily because they're thin, so they're not going to be getting trapped on the walls as they're being pushed to length, and then obviously the excess sealer can sort of vent out. But it's a bit of a double-edged sword because they're easy to place in, they're also really easy to pull out. So you have to be really careful that you don't pull these out. And then in this case, you know, I'm just going to condense it down and push it all, and then I'm going to get rid of all the excess sealer. In this case, Bioceramics just washes away nice and easy with water. And then, you know, when we look inside the cavity here, we can see that it's really difficult to remove all excess water. And obviously this can't be here when we finally restore the tooth. So what I'm going to use is some paper points just to remove this water excess. And then I am going to use some Vitrabond in this case. So I think it'd be really difficult for me to get some bond down there and light cure it nice and easy. So in this case, I'm just using this dual cure GIC, and this is placed in an Acidose tip. So it's like a tip that you can load up and put a little plunger in and put it on your composite gun, and you know, you can pinpoint where you want to put this GIC. Once we've filled the space that's directly over the composite, I'm just going to use Scotch Bond and SDR to finally restore this tooth. And then when we look at the post-op radiograph, looks beautiful. Looks really well condensed. It looks like it's to length. And overall, I'm really happy with this tooth. And you know, if we look at the final restoration, it looks much better than it did. You know, this tooth now has gained functionality and it's ready for a crown. And overall, thanks for watching. Listen, if you love these videos, I like making them. Please like and subscribe. If you feel like what I've done today you don't agree with, or you have any questions, please comment in the section below. You know, I strongly advise strong criticism on this channel, because this is how we learn. You know, I've said this before, I learn so much from this channel from all of the viewers. So if you think you should have used a different bond or a different agent or a different way of restoring this tooth, if you think the way I've restored this tooth today with this GP cone is wrong, you tell me. I want to hear how you do it, because in dentistry, you know, it's a funny saying in English, but you know, there's a million one ways to skin a cat, and you know, you could have done this loads and loads of different ways, but I suppose in a way I saw a problem and I overcame that problem in a kind of novel way. You know, and if you love the channel, you can support the channel by becoming a member. We've got early access to content and exclusive content, new exclusive content on the way. And I will see you in the next video. Bye-bye.